yes,
prostatectomy,
yes,
is the fear of incontinence.
that's right.
And
That's the main fear, isn't it?
long-term incontinence.
Now, in terms of the incontinence, for example, as we discussed before, majority of patients, and that is 95% plus, will be continent. And the time period that patients usually achieve continence is between, a week or two, all the way up to about 6 months, and we can't predict in individual cases how long that's going to take. However, with the refinement of the surgery, and as I mentioned to you, what we are doing now is we're trying to do a very tight bladder neck. So patients already have a lot of the muscles around the bladder neck spared, and that is when possible we can do that. Sometimes if the prostate is very large we can't. But if it's a tight bladder neck, then we're sparing a lot of those muscles. And the other thing that we're doing more recently is we are using a Rocco stitch, which is a description of a repair of the posterior bladder to the Denon-Villiers fascia, which is part of the attachments of the prostate, and also to the posterior urethra. And what we have done what we've achieved with that is to actually reconstitute the whole anatomy like it was before, without the prostate bud, and also lifting the posterior urethra. By lifting the posterior urethra up, you're almost providing like a suspension, like a cushion for the urethra. So this is the urethra. You provide almost like a cushion, like a suspension of that.
Why is that desirable?
That's desirable because that lifts up the urethra and almost provides a bit of a compression on itself, on the urethra. Okay. And also it increases the intra-abdominal length of the urethra. Yes. That means that the urethra, the length of the urethra that's inside the abdomen, the longer the intra-abdominal length of the urethra, the more likely is that the patient will be continent.
And the more compression you can
exactly.
place
so
on it than control.
Correct.
Yes.
Because if the urethra is not also intra-abdominal, so if the compression, the abdominal pressure goes straight into the bladder, you'll leak. So the continence is to do with the intra-abdominal length of the urethra.
Yep.
So you have that same pressure that is applied to the bladder that is also applied to the urethra at the same time that keeps you continent. So you have the pressure that closes the tube. You have the pressure that closes the tube of the urethra, so the bladder then is not leaking, so the urine is not leaking through.
So are these techniques pretty recent then, aren't they?
These are pretty much recent techniques. I mean, in terms of the Rocco stitch, and I have modified even the Rocco stitch technique. I've modified it to what I thought is probably a way to do it by getting the posterior urethra put a bit more forward and inside the abdomen and lifting it all up. So these are the new ways, and that's why, as I mentioned to you before, I mean, I've been to Europe and the United States to look at what's new in this area and how we can improve on these procedures. So to make it better.
Far cry from 15 or 20 years ago then.
That's correct. That's very correct. I mean, even 10 years ago, or even 5 years ago, if you look at it, the procedure is not exactly the same. And certainly there's been an evolution and an evolvement of the actual procedure itself. So it's good news. And as you can see in your case, I mean, normally sort of with an open procedure, you would be in hospital for a period of 7 days. So with the keyhole, and if you look at the keyhole procedure, whether you do it robotically or whether you do it with laparoscopic procedure, the patient leaving the hospital will be pretty much the same.
Yes.
So there's no major advantage in terms of leaving hospital earlier with the robot or with the keyhole. It's pretty much the same. And the outcomes that we are getting is, I did present my own studies in Europe, looking at the laparoscopic procedure compared to the open procedure, and this is comparing with the best open surgeons in the world. The positive margin for T2 disease, which is the disease that is confined to the prostate, the best open surgeons in the United States have 2.5% positive margin rate for T2 disease, and with the laparoscopic surgery I've been able to achieve, and this is my own patients, my own data, 2.9%. positive margin rate, which is, as you know, and you're a scientist, statistically there's no difference between the 2.5 and 2.9. So I think we've been able to achieve good results.